Hey y'all, today we are going to talk about all things epidural. As a pelvic floor physical therapist, one of the plans that I hear from my patients and my labor and delivery workshop participants all the time is that they are just planning an epidural. And I don't think there's anything wrong with that, but what I do try to lead them through is a little bit of strategic planning of how to use that epidural strategically, keeping it part of the plan wholeheartedly, but using it strategically based on what we know about what helps labor and delivery progress and what can work against that progression. My name is Amanda. I'm a pelvic floor physical therapist whose practice is centered around all things pregnancy and postpartum, which includes labor and delivery prep. I work one-on-one with women every single week in my practice to help them prepare for labor and delivery. And I also work with couples in a group setting in my labor and delivery workshops. And everything that I lead them through with strategic planning is what we are going to talk about in this video today. So what that includes is some of the things that we know helps labor to progress and things that you can do to help your baby work through birth canal and work through pelvis, why we might want to hold off on that epidural for a little bit based on those things that we know can help labor progress. But also I like to give this very strategic question that you can ask yourself throughout labor so that you know when it is a good strategic time to ask for that epidural. So let's get into it. Okay, first let's talk about things that we know will help baby progress through birth canal and especially progress through the pelvis, which means that we are taking an active role in helping labor progress. Your absolute two best friends when it comes to that is movement and gravity. So movement meaning how much can we move around, how active can we be, how many positions are we able to move in and out of. I want you to think about every time you move and switch a position, you're opening up a different side of your pelvis. So as we move, as we switch positions, walk around the room, get one leg up on a chair, get into tall kneeling, get into squatting, whatever position sounds comfortable to you to switch into next, we are just giving lots and lots of mobility to this pelvis because baby working through birth canal, especially through first stage of labor, what we're really talking about is baby working through the top of your pelvis or the pelvic inlet because we don't really get to know where in your pelvis baby needs room at any given time. But if we just keep moving and just keep opening different parts of the pelvis up, eventually we're going to get to that one position that really opens up the space that baby has been needing so that he or she can scooch down to that next station. And then we keep moving and so on and so forth. We just keep incidentally giving baby the room that he or she needs next. So movement is key. Gravity is also a big piece of it. So being able to stay upright for as much of labor as possible because we don't want to get into a position that makes it harder for baby to keep dropping and dropping and dropping through the pelvis. As soon as we're laying flat, then baby just doesn't have that advantage of working with gravity and going in the direction that gravity is going. Another piece that I want to point out is being very strategic with knowing what the role of your pelvic floor is during labor. And you will hear me say this over and over again because especially in my labor and delivery workshops, it's a big pillar of education that we relate everything back to. The role of the pelvic floor during labor is to get out of the way. That's it. There's no other role that the pelvic floor has to help with labor and delivery. If you look at the anatomy of where pelvic floor muscles are, pelvic floor is that hammock at the base of your pelvis. And so if we think goal of every single contraction is uterus contracting from up here to push baby further and further through birth canal and into pelvis and get baby into a position that's ready to exit the pelvis and be pushed out, you can see that the more tension that's held in these muscles, those muscles are a direct opposite force to what those contractions are trying to do. So our biggest goal during labor when we think about what we want pelvic floor to do is to leave it out of the way and to do what we can mobility wise, breathing wise, pain management and pain coping wise, which we'll talk about, to make sure that that pelvic floor has as little tension in it as possible so that it isn't being a counteractive force against what those contractions are trying to do, because that really gets in the way of labor progressing and really starts to make those contractions less and less and less efficient. If you want to know more about pelvic floor's role during labor, I have an entire video on that. It's one of the first YouTube videos that I filmed, and so I will link that in the description of this video so that you can watch that after this one because it goes into a lot more detail about what I mean and some of the strategies you can use. And also if you want to know more about some of those labor and delivery positions and working with gravity and options for those while you labor, that's a big part of what is included in my free birth wishes worksheet. So I'll also link that in the description. So next, let's talk about why we might want to be a little bit more strategic about when we ask for your epidural, because Some people just say, I'm going to ask for it as soon as I get to the hospital, which could be totally fine. But something that I want you to know is then we're losing that asset of being able to stay fully against gravity, of being able to have all of these lovely movement positions and giving baby different space and different mobility through the pelvis. One, obviously, with an epidural, we lose that feeling and that full muscle control from the waist down. So not only do most hospitals have the policy that they want you staying in bed as soon as you get that epidural, you also might not even have full control and full access to all of the different positions that you want to try, even within the bed, depending on how strong your epidural is and depending on how your body reacts to that epidural. Also realizing, this is a big piece that a lot of patients don't realize as I'm talking to them, that with an epidural it also means a lot more monitoring. So with fetal monitoring, they're always going to want to be monitoring baby and baby's heart rate. Without an epidural, you may be able to have intermittent fetal monitoring, so it's not this continuous thing that's strapped to your body. But with an epidural, most hospitals are going to want to put a band around your belly that is consistently monitoring baby's heart rate. With that, some moms find that band just extremely uncomfortable, and so it just kind of takes away some of that comfort that you get to have without having that band around your belly. But also, there's a lot more monitoring for you once you get that epidural on board. They're going to be consistently wanting to monitor your blood pressure, so you might have a blood pressure cuff around your arm at all times. They're probably going to be monitoring your oxygen saturation a lot closely, so that little thing on your finger is going to stay there. It might come with more IV fluids and more stuff going on with your IV, or if you didn't have an IV before, you asked for a hep lock, now you're continuously attached to that IV. So just realizing that that epidural comes with a lot of attachments and a lot more monitoring, which is another big way that it limits your freedom of movement and your freedom of mobility. With that freedom of mobility taken away, and also just the level of comfort. So now we're attached to things. It makes the whole situation feel a little bit more medical, sometimes a little bit more anxiety inducing, which can affect your nervous system. All of those things we can think about could potentially limit the progression of your labor. So that's just one piece of why we might want to wait on that epidural instead of getting it right away, if what we're going to talk about next remains true, so that we can continue to use mobility and gravity, and you can stay more comfortable and maybe just a little bit more anxiety free and not attached to monitors beeping and all the things going off in the room. That's just one reason why we might want to hold off on the epidural and not get it right away, and instead wait for a more strategic time. Okay, so when do we know that it is a good strategic time to ask for an epidural? At the end of this, you're going to have a question that you can ask yourself to run it through a litmus test, like, is now a good time to ask? But first, we have to understand the difference between pain coping and pain management or pain control. Pain control and pain management is what comes with something like an epidural, where it is a pharmacological something that we use so that you don't feel the pain as much. So we're physically taking the pain away so that you don't have it to cope with anymore. When we don't have something like that on board, then we're talking more about how well are you coping with the pain, which means you're fully aware of it, you know it's there, you know it's happening, but how are you reacting to it? So good pain coping looks like when a contraction comes on, as it reaches that peak sensation during the contraction, what's your breathing doing? Is it a controlled breath? Is it still deep? Do you feel it getting to your pelvic floor? Do you still feel like you're taking those deep diaphragmatic breaths and you can slow them down? That's good pain coping. Or when that pain, especially when it reaches the peak, do we lose control of our breath a little bit, and it's those short, shallow breathing pattern that shows us that maybe we're starting to lose a little bit of the coping skill because those contractions are getting so intense. The other thing that I like to give you to watch for is your clenching pattern. So good pain coping, we want to be able to leave our jaw relaxed, leave our shoulders relaxed. We're not clenching our fists. All of that, this is where pelvic floor comes into play. All of that is a pretty good sign that we're also not clenching this pelvic floor and getting it in the way of a contraction and making those contractions a lot less effective. So if we are still coping well, we're breathing deeply, we're controlling our nervous system against the pain, we're able to leave things semi-relaxed at least, we're able to hum through it, breathe through it, all of those really great signs of good pain coping, then not only do we still have, we're moving, we're mobile, we're against gravity, we're a little bit more comfortable because we're not strapped to things, and we know that pelvic floor is staying out of the way, then we're probably in a really good place of helping labor progress. But when you reach a point where you're like, okay, for the last few contractions, I don't think I've coped well no matter what I've done. I've lost control of my breathing. I feel my shoulders really clenching up and my fists really clenching up. I'm holding my breath during it even. Those are all signs that maybe we're losing a little bit of a control over the coping because the pain is getting more intense and it's getting more significant. And when we reach that point, we have to think about, okay, that probably means I'm getting pelvic floor really in the way of that contraction, and I'm limiting the efficiency of what my uterus could do to continue to move that baby through my pelvis. And so I will tell patients, if there's somebody who really, really wants to wait on their epidural as long as possible, then okay, let's, once you notice that and you call it out, maybe give it a few more tries. But if you're like, you know what, I'm just not doing a good job coping, it might be time to ask for that epidural. I have other patients that are like, I don't want to wait that long, but I do want to make sure I can move as long as possible. Maybe they don't even like hang out and see if they can control it. It's like 1 or 2 contractions. They're like, I didn't control that one well, it's time for the epidural. Those are completely personal decisions. But the question that you get to ask yourself is, how am I coping? Because I like that I'm moving. I like that I'm not strapped to things. I like that I'm against gravity. I like that it feels a little less medical because I'm not strapped to monitors. I'm not stuck on the table. But am I coping well? Because if you're not coping well, that's when we get to use an epidural strategically instead of just willy-nilly because we weren't taught what the difference between pain coping and pain management is. So if we know the difference between pain coping and pain management, we know what to look for, signs to look for on the body. Tell your partner signs to look for on your body as well. This is a decision to make or a conversation to have with your partner, with your birthing partner, or with your doula who's in the room with you so that they can help you watch for some of those signs as well, so that if you're like so in it and you're not catching those signs, they can be the one to be like, hey, so for the last few contractions, your breath has gotten kind of away from you. I see lots of clenching in your shoulder. I notice that you're clenching your fists, and they can help talk you through it and see if we can get back into that back on track with coping with the pain as the contraction builds and builds. Or they can say like, do you want me to ask the nurse if we can start to get the process started for your epidural? So it can be really helpful to just have someone else in the room that knows what's going on with that and what to watch for instead of just you. But at the end of the day, that's your litmus test. That's what we're looking for, and that's the question that you're asking yourself, so that we know that we are using all of the assets of movement, gravity, comfort, all the things to help labor progress. But when it's time, we use that epidural strategically so that we can get that pelvic floor out of the way, and so that the contractions can do their jobs and do their jobs well and do their thing, working that baby the rest of the way through the birth canal. I want to point out again, especially when it comes to having a conversation with your partner, being able to communicate your birth wishes and kind of what the plan is through labor for not just when do we get the epidural, when do we wait on the epidural, but all the other options that come with labor and delivery. That free birth wishes worksheet is a really good tool for that. So it's something that's really great for if you sit down and think through it on your own, or if you and your partner sit down and think through it together, but it just gives you a communication tool with your partner, with your doula, with your birth care team, so that you have something written down to make sure you don't forget something that's super important to you that you want your birth team to know. It just gives you that communication tool and decision-making tool as well. So don't forget, if this is something that you're like, oh, I should really start thinking through some of these things, don't forget that the link to that is in the description of this video. I hope that gives you a really good process to think through if you're planning an epidural for your upcoming labor and delivery. I hope it gives you a little bit of a strategy to think through, and also shows you why, even if you're planning an epidural, it's still probably smart to learn some good pain coping and good positions and other comfort measures to go along with your labor and delivery, more than just the epidural. There's actually a lot of other reasons to go into that, but maybe that's a topic for another video. I hope this was super helpful, and I will see you guys next week.